Good afternoon. I'm Claire Brindis, and I'm really delighted to welcome everyone here. I'm the director of the Philip R. Lee Institute for Health Policy Studies, and I want to give a very warm welcome to Karin this afternoon, who I'll introduce in a moment. But I think it reflects Karin on the fact that this session is co-sponsored by a number of colleagues and collaborators, and so I think that speaks very highly of your own career pathway. Our session this afternoon is co-sponsored by the Department of Pediatrics, the Benioff Hospital, the UCSF, UC Consortium on Law, Science, and Health Policy, as well as the Children's Specialty Care Coalition of California, and a very warm welcome to all of you, because you represent a very important coalition of all the major children's hospitals and providers concerned with children with special needs. And so it's delightful for us that you're here with us at UCSF. While there are relatively few people in this room, tomorrow is a University of California holiday, so I think some people are taking advantage of leaving a little earlier. Karin Rhodes is someone who has lots and lots of different interests. I don't think it's attention deficit disorder, but
maybe. Maybe.
But Karin is an assistant professor and also the director of the Division of Health Policy and Research in the Department of Emergency Medicine at the University of Pennsylvania. And a lot of her interest has to do with access to care and what are the barriers that children face, particularly for those children who are enrolled in Medicaid and the Children's Health Program, and she'll talk about that with you this afternoon. But she's also involved in a number of other studies investigating the quality of emergency services, access to follow-up care after that emergency medicine visit, or emergency department, as my son, who's an emergency medicine doctor, has taught me. It's not the emergency room, it's an emergency department. And the intersection between acute care and mental health, social services, and criminal justice system. She's also received funding to evaluate the impact of computer screening on doctor-patient communications. And in addition, she's been evaluating the psychological profiles and designing interventions for self-identified perpetrators of family violence. So you can see that she brings to us this afternoon a very interesting and intense portfolio of projects. So Karin, welcome.
Thank you so much. It's an honor to be here, and I want to thank the people who've invited me, and love presenting this work. First, I'm going to give you a bit of an overview, some background on the role of public insurance in children's health care, and tell you a little bit about the impetus for the study that I'm going to describe. And then I'm going to focus on the methods we use, which was audit methodology, the use of simulated patients to measure access. And I will present, obviously, the results. And spoiler alert, disparities exist by insurance status. But I want to actually focus a little bit on this talk on how and why those happen and what the providers say about it, and how we could maybe see what we can learn by variations in practice characteristics that could inform potential solutions. And so why study access to care? And there's your hospital of the future, right, which I put on there, which is going to be big and beautiful. Isn't what we care about, beautiful space for patients, patient-centered care, quality, and health outcomes? And I think, yes, we do about all of that, and we want to provide the best advanced care possible. But I think most people would agree that access is a prerequisite for quality. And the first question is, can children even get in the door? So by way of background, 42 million U.S. children are publicly insured. The vast majority of this is Medicaid and CHIP, and these are entitlement programs. So this is, I think, 2009, 2010 data, so that's probably higher by now, because in a poor economy, there's more people eligible and more enrolled just when you can least afford to spend more on it. So federal law protects Medicaid, and says that access under Medicaid, it says Medicaid must provide the same access to services that is available to the privately insured children living in the same geographic area. And yet, in 2010, the Office of the Inspector General of the Department of Health and Human Services found that most children in 9 states did not receive Medicaid-required preventative screenings. So it was that sort of data that led to the impetus for this study, which was a class action suit, the Mimosovsky case, and it took me about a year to learn to say it, which was a class action lawsuit that was initiated in 1992 on behalf of children in Cook County, Illinois. Now, Cook County is the second most populous U.S. county in the country, and it's home to 67% of the state's 1.5 million publicly insured children. This lawsuit was supported by the American Academy of Pediatrics and most all of the children's hospitals. And it wasn't settled until 2004, so it took 12 years to settle this lawsuit, and it settled on behalf of the class of children, and they found the state in violation of the State Medicaid Act. And when you settle in law, it's a consent decree. So this was taken pro bono by health and disability advocates and national poverty law, and the law agencies did not make any money on this case. They were very happy just to advance access for children. So there was a consent decree, and the state agreed to better inform families of the need for EPDST services, to increase reimbursement rates for primary care and preventative dental. But notably, they did not increase rates for specialty care or restorative dental. And that was partly because it's hard to prove that it was needed, and they didn't really have the data on it. So instead, the state agreed to commission a study on children's access to specialty care. And it took them about 4 years to get it together to do this study, and this is the study. So actually it was the judge who decided that I should do the study. And I had to think about it. So the study I called Measuring and Monitoring Children's Access to Specialty Care, and it actually took place over 3 years. The first whole year was just qualitative, learning about the system and how children get into specialty care. And as part of this, we did a beneficiary type survey. The state opened up a complaint line that was open for 3 weeks and actually solicited in English and Spanish feedback from consumers, both their privately insured state employee and families who are insured by Medicaid, whether or not they'd had any barriers to specialty care. And they wanted both good experiences and bad. So we had 372 beneficiaries who were short surveyed, and then we did in-depth surveys with 177 parents, primary care providers, specialty care providers of all sorts, and administrators and health services experts. So qualitative was phase 1. I will present a little of that later on. This talk, though, is going to focus on phase 2, which was the audit study. And the goal of the audit study was to determine the existence and extent of any disparities in access to specialty care for children up through age 18 in Cook County, Illinois. So I'm going to spend a little time talking about audit methodology because it is a time-honored tradition, part of a group of studies that have been going on many, many, many years, which is basically simulated consumer studies, and they've been used for a variety of both education, measuring discrimination, and in marketplaces using mystery shoppers that basically report, assess how the consumer's experience dealing with the business so that they can improve quality. In healthcare, it's been done fairly recently, and does anyone recognize they actually use fictitious patients? Does anyone recognize the fictitious patient in that? Yes? Know what? Yes? Who is it? Right, and One Flew Over the Cuckoo's Nest. And that's actually sending a real patient into, not him, obviously, but there actually was a study done where they sent real patients into mental hospitals, only they weren't patients, they were actually psychiatrists, and they noted the kind of care that was given, and they were all prescribed medications that they palmed, and once they got in, I think they got in saying something, I hear a word like empty, and they were all admitted. And when they got in, they behaved completely normally, and nobody ever picked up that they weren't a real patient. Their diagnosis was never changed. They got a variety of diagnoses for even the same symptom, and some of them started reading their psych books and all this stuff, but they reported on it, and it was, I think, it was a little bit of scandal about state mental hospitals. So in any case, but that's sending a real patient in. There's also different ways that you can do audit studies. There's one study that is actually quite brilliant that all they did was send resumes out. And people have heard of that one, where all they did was manipulate the name and the education and experience on the resumes, and they used some African-American sounding names like Jamal and Letitia, and compared to Emily and Greg, and found that having a white sounding name was the equivalent of 8 years of experience, and that the white callers were, many more times likely to get calls back. So you don't have to use real patients. So this all falls into audit research, and there's some strengths and weaknesses that I'm not going to dwell on a lot, but I want to basically say that it's good in studying getting access. It's perfect for access, entry into a marketplace. It uses a deceptive design because you're trying to observe behavior as usual. So asking for consent might influence what people say and isn't quite feasible. But importantly, it doesn't identify the reasons that you see behind the observed behavior. So you have to do qualitative work or other types of research to get at the reasons. If you do a good job sampling everybody who could possibly be in that, you can take a random sample. So anyone who's at risk of giving an appointment, say, you can get really precise population-based estimates with nice confidence intervals around it, and it can be used to track access over time. So you need pretty comprehensive lists, and you have to be able to supply the same information that a real patient would have. Sometimes that includes insurance numbers, and certainly addresses and stories. So the strength of this is that it studies real-world behavior, and you get actually to find out what people actually do in real-world practice as part of business as usual, and not what they say they do. And so, as such, it's very persuasive, and politically, people believe the results. And you don't have the problem of missing data or selection bias, or physician surveys, for example, have very low rates in the around 35%. So you have to wonder about the people who don't respond to the survey. You can't quite trust it. And even patient surveys aren't always good, especially if they may not realize they need specialty care, for example, or their child needs specialty care. So it's a hard thing to measure just asking parents if they've had trouble getting access. Although clearly I think you get the direction correct, but if you want a precise measurement, you want an experimental design, and that's what this gives you. You also want to be able to control for confounders, like language, transportation, all the other barriers to access. And so you can isolate the impact exactly of the variable that you're studying, and it's not relying on other things. So in this study, we wanted to the question was do we have equity in access? So this is a class, it's following on a class action suit saying that there was unequal access. So the question here was, is there equity? You could study other things other than equity using the same sort of process or the same audit methodology. So in any case, so the key is this study measures one thing and isolates not all the other barriers to specialty care access that we know can exist, but provider participation in insurance. So here's the methods that we used. We used University of Chicago Survey Lab, and we had trained research assistants. They posed as mothers, and they called a randomly selected stratified random sample of subspecialty clinics, asking for the earliest appointment. They use a computer, so they're going through, the script is exact, and they don't volunteer their insurance status unless they're asked. And but if they're given appointment without being asked, then they confirm that their insurance is accepted. So they called, in this study, you don't have to do paired calls, but we did paired calls. They called the same clinic twice, and the only thing that varied in the call was the insurance status. And our outcome variables of interest were ability to schedule any appointment and the wait time for that appointment. So note, all appointments, we made real appointments, these weren't hypothetical, and we canceled them immediately with an excuse at the end of the call. So here we selected 9 subspecialties to audit and 8 conditions, because pulmonary and allergy immunology both were tested with asthma. So our criteria, and we relied on primary care and specialty care physicians in each area to pick things where that warranted need for timely care. And we wanted urgent appointments, but we didn't want to be referred to the emergency department, so non-emergent. But and frequently we'd say, I've already been seen in the emergency department, and they had all gone to a primary care doc and were referred to a primary care doc. We wanted to pick conditions where an effective treatment exists that could improve morbidity, mortality, but they had to be very common because we didn't want anyone to remember the scenario. So here we used our beneficiary surveys right off the top to figure out where people which services they were using a lot and where they might have some access difficulties. So here are the specialties and the health conditions we picked, and by age. And so we had severe atopic dermatitis in a 9-month-old, where the primary care physician was referring and the mother was already slathering them with steroid cream, and the kid was scratching and the mom was going crazy. And obstructive sleep apnea with some hearing loss and chronic bilateral otitis media for ENT, and new onset type 1 diabetes, and afebrile seizures that seen in the ED and referred followed up with the primary care and referred to neurology. A fractured forearm with a possible growth plate fracture. For psychiatry, we picked a 13-year-old with acute, severe, new onset depression and some vegetative signs that made you wonder if something else was going on, possibly early schizophrenia. We had the scenario. And then we had persistent uncontrolled asthma with multiple ED visits. And for the dental scenario, a fractured Ellis type 3 dental fracture of a front tooth, and I'll go into that in a 10-year-old and a permanent tooth. So we developed scripts, and the scripts were vetted by our experts in every field. And it's interesting, for diabetes, we started with type 2 diabetes, but that our primary care consultant really thought this needed to be seen. But our endocrinologist said, no, that should be handled by primary care. So we went to type 1, or close enough. So basically, we started out every scenario with the age of the child and that they wanted to see that specialist. So if the person was out of scope, like for example, they're an endocrinologist, but they don't see kids, they would reject it right offhand before they knew what the insurance status was. So, and then we had answers to all the questions that we did a huge pilot before we actually started the audit. So we knew what sort of questions would be asked, and we had answers for all of them. We had names for the primary care doc, and we used an intersection of where they were located. So now, in addition, we wanted to, because a lot of times people have medical records, and because from our qualitative work, we realized that geography was important of whether or not someone would take a kid with Medicaid. We did geocoding, and we actually went online with Google Earth and found places where for the kid's home address and the primary care doc's home address, and that was near the specialist, near enough but not close enough that they'd actually know exactly where it was. And the same thing with emergency departments, like if they said they were seeing an emergency department, we had access. Fortunately, we had a lot of help through the state here. We knew which ERs the docs were on staff, so we picked an ER that was close, but they weren't on staff, so they couldn't go on and look up that x-ray or whatever. So, this gets into, the hardest thing was to define the sampling frame because, as you know, 2/3 of specialty care for children, if you think of all the way up to 18, are taken care of by non-pediatric subspecialists. So we didn't want to leave that group out. So what we did is we had claims data, both from Medicaid and from private, for all the state employees, and we used that, plus we had the licensure data that said if they took all kids, which is what they call, it's a combined program in Illinois. I know here you have Healthy Families and then you have Medicaid. It's just a combined one program there called All Kids. And so if their licensure said they took all kids or Medicaid, and we also had all the children's hospitals gave us their referral lists, so we had those. So we merged all these lists together, and including Illinois Academy of Pediatric gave us their list. So we put them all together, and then if there was any evidence that that they saw kids, they went into our sampling frame. Then we deduplicated by phone number, because some providers specialists go to multiple places, and a lot of times they have different phone numbers. So we deduplicated so that we would basically, we're not sampling providers, we're actually sampling clinics or practices, a unique phone number. So, and that gave us the sort of a sampling frame that was in proportion. Providers would be more likely to fall into our sampling frame if they were from a big practice. So, and then we randomized. So we did a stratified random sample that reflected the distribution of that specialty, both within Chicago, without Chicago, and then we randomly assigned to a Hispanic caller, a black caller, a white caller, who had appropriate accents and names and children's names. We weren't testing race or ethnicity, but we wanted to control for it, because Chicago is a pretty segregated city, so we wanted to make sure that that wasn't affecting our results. Then basically this is what our sample frame looked like. So we found the ones who were, they excluded, were ineligible. Basically they let us know they didn't see kids or kids of that age. Only 4 were excluded because they couldn't complete the protocol. So other than that, we pretty much had complete data, and we, because you're doing paired analysis, you don't have to have huge sample size if you're comparing the same clinic to itself for Medicaid versus a private insurer. So we were able to test quite a number of specialties, and we did dental. Now with dental, it's important to realize that they actually have a dental managed care program there in Illinois, and that are sort of say that they sign up for it. And then there are people who do not sign up for dental managed care, but we decided we'd sample both of them, and I'm glad we did. So I want to give you some of the results. So first, the dental results. And for the dental results, I'm just going to present the ones that were actually Medicaid providers. So Medicaid providers only gave an appointment to 68% of the kids with a fractured tooth, whereas the same practices, the same kid, they gave 100% if the kid had private insurance. Now, mind you, some of these that turned them down were willing to take cash, which is not really legal from a Medicaid patient. So it uncovered a number of quality issues in that system. That odds ratio was about 18. Now, I will say we also called providers that were not listed and said we had Medicaid, and 7% of them did give an appointment, which I would say is equivalent to charity care because they weren't signed up. Now, in fact, they could have billed the state, but many of them said they didn't know that. So basically charity care for that group. Now, the good news about this is if they gave an appointment, they gave a timely appointment, and they didn't discriminate by wait time in the dental condition. So with the LS type 2, 3, at least in emergency medicine, we say they should get in within 48 hours to avoid like losing the tooth, things like this. And I have a very sentimental, my daughter had this exact same dental fracture, and I know how much work it is. So it's interesting, these dental results, we got so much more feedback from the dental community and concern about it. They literally have gone on and made like 7 or 8 changes in the way they're doing things as a result of the dental results. So I would say not so the medical community. So here's the results from the medical specialty care situation. So on your left are the results across all specialties. And so here we have basically 7 specialties, 8 specialties collapsed across condition here. But so what you can see is that 2/3 of children who had Medicaid were denied an appointment, no appointment at all. And compared to 11% of privately insured. So having private insurance didn't necessarily guarantee it either. So keep that in mind. But we saw this disparities. It's a relative risk. The odds ratio is 31, but I think of a relative risk of about 6 that they'd be turned down. Orthopedics had the most discrimination by insurance status. And psychiatry had the least, but they had the worst overall access because a lot of them did not take insurance at all. So very poor access overall, regardless of insurance, for pediatric psychiatry. And it was across all specialties, we saw the same trend. So now, unlike dentistry, there was an additional, we identified an additional dimension of access disparities in medical specialty care, that if there was a 20-day difference if you had Medicaid, if they gave you an appointment. There this analysis is done only among the ones that gave appointments, because you can't look at wait times if they didn't give you an appointment at all. They were less likely to give an appointment, and if they gave an appointment, it was on average an extra 20 days for a kid who was insured by Medicaid. So now this is the part I love, because I sort of love the qualitative piece. The hard numbers are wonderful, but we did all these open-ended, semi-structured interviews, and these were done anonymously with specialists in primary care by the survey lab, and we used sort of this semi-structured, and we just sort of asked them their experience with specialty care. And so what did the providers say? Basically, right off the bat, they said it's how much, Medicaid doesn't pay enough. And also slow pay. And there was a lot of pending claims. The state had run out of money, and they just sort of put the claims aside. So that, and they talked about the hassle factor, that claims would be shipped back. They had to add more data before, so it was payment amount and procedures. Now, I will say, Medicaid was paying $100 for a moderately severe specialty code. Here in California, you pay half this amount for the same code. Now, and Illinois actually bumped it up almost 6 months before we did this study, because they knew the study was coming, first of all. So they went from like $51 up to $100 for this moderate severe, but they didn't advertise it really well. So I think that people still thought the same thing. But in any case, it's interesting. Private insurance on average was paying $160 for the same condition. And we actually tested out, sort of for this code and conditions. And a lot of providers cited institutional pressures, whether they're blaming their institution or it's real, that their institution told them they had to improve. I'd be happy to see the Medicaid kids. My institution tells me I have to improve my payer mix. And they literally talked about limiting the number of Medicaid patients. Like, we see one new Medicaid patient a week, even when they were willing to see them. And that there were different queues, there's the Medicaid list, and then there's, that sort of explain the discrepancy in wait time. So, as an example of the institutional pressure, here's a developmental pediatrician at an academic hospital. Yeah, we're cutting down. In the last budget revision, we were called in, we're losing money. You are losing money, so you need to improve your patient mix. So what we're doing is we're just trying to restrict the number of Medicaids. We have a number of slots for Medicaid, a limited number of slots. So that's definitely, that sounds like pressure. And I did hear that a lot from quite a number of specialists that I spoke to as well. But what I thought was interesting here is they also talked about the strategies by which they rationed care, what they got in the patients that they felt most needed to be seen. And I think that's informative for how things that you could actually do to change things. So, for example, allergist, immunologist said, at first I took all kids with public aid, and then I noticed that as I learned more about the business of medicine, I was not getting reimbursed well. So then I quit taking all public aids. I would still see the more serious asthma and food allergy kids. So she decides she's going to see the kids, who, are more serious, and that's one way, So another developmental pediatrician, we prioritize kids based on geography. If they're in our area, we'll see them. And a neurologist, talking really here about formal relations between FQHCs and the hospital. So I think the hospital made a policy of providing Medicaid slots for certain primary care physicians that were affiliated with the hospital. So formal relations, and they'll take them if the hospital will take them, so to speak. Another psychiatrist, once in a while I'll take someone with Medicaid, but usually what happens is someone will call me and it'll be like this tremendous hard luck story, and this went on for quite a while. It was really sort of heartbreaking. And I make exceptions for very, very, very young children. I do that because there's no one else willing to touch these children. An orthopedic surgeon basically says quid pro quo. Certain primary care docs, they refer us, they're good patients, and so we'll take it upon ourselves to see their Medicaid patients as well. So, and then some of the primary care docs, and maybe this will resonate with some of you, from community health centers, we admit to such and such, and we've had a long relationship with them, and so it's very easy communication to get in. So sometimes if there's an established relationship, the hospital agrees that we're going to see the patients from this community health center, it's not a problem, and that's a potential solution, is just formalizing relationships. Otherwise, the other people sort of reported a lot on just tremendous amount of work to get kids in. I personally need to call, and it has to be me, not a nurse or resident. It needs to be attending to attending. So it takes a huge amount of time to get some of these specialists to see patients, and it's almost a favor to me that they're doing it. And another pediatrician said, the primary care doctor can call the specialist and ask for a favor. We guard them carefully, our favors. So just trying to figure out how they go about this rationing. So, and then I'm an ER doc, realize, so I was very interested in this whole area. So the specialists have frequently reported, and this is just an example of one, so some patients who can't get an appointment will go to the ER and get sent in that way. And once they're in the system, then I'm obligated to see them. And they were like in equipoise about that. That's fine. They got in the system, they came into my ER. Another pediatrician says, actually admitted, so the idea is if I send them to the emergency room and they need to be referred to a specialist, they get a specialist. So I'm bypassing a number of problems, not all that begging, I'm fully aware that I'm crowding the emergency department. So this is I'm actually working on a paper on that because it was so prevalent. And I don't think people have really realized how they're using the emergency department to actually get access for patients. So in any case, so just summarizing that. So here's the strategies that were used to ration care. Limited specialty care appointment slots to kids with Medicaid. The severity of the health condition, and specialists taking responsibility sometimes for patients who lacked other alternatives, geographic proximity, the hospital affiliation, formalized arrangements, personal connection, professional courtesy with the primary care physician, and informal arrangements, and the emergency department. So we did more analysis looking at different characteristics of the clinics and whether or not they actually discriminated more or less. So we looked at academic affiliation of the practice and the neighborhood characteristics where the actual clinic or practice was located. And then we looked at the local capacity of providers within the specialty. That was a limited analysis because we only have one area, Cook County. It would be better to do that comparing across the country. So in any case, so here were our results. First of all, neighborhood location of the clinic was huge. It was for every 1% increase in poverty, there was a 5% decrease in discrimination against Medicaid. So having a clinic located, so this has implications for increasing access, is having the clinics where the kids are. But academic affiliation of the medical center was associated with a 45% decrease in discriminatory denials. So here we're, again, just looking at the group that gave an appointment, the group that gave an appointment versus the one that didn't in this case, and found that if they were affiliated with the academic center, they were much more likely to see the patient. Still not super good, but better. Unfortunately, they discriminated in a different way because you could see the results of the the separate lists for kids with Medicaid, because we found that even though they were more likely to give an appointment, if they got an appointment there, they had to wait a lot longer. So on average, 41 days longer than a kid who was privately insured. So in any case, so the implications for spending scarce resources, Illinois is broke, as California is, but I think the implications of the data are that to target providers who are already taking care of publicly insured children to see more. You could try to spread that money out, raise rates all over, or you could target people who are already seeing 20% and say, would you see 30% with a given incentives? I'm saying is how you might want to use any money you have. And the other thing is to provide incentives to increase the presence or outreach of specialty clinics into low-income communities, because it was associated with a lot less discrimination. And then I think that if we're going to reallocate resources to academic medical centers who become ACOs and help take community health center patients for specialty care, you could make any resource allocation or dish payments contingent on equity across both dimensions of access. So all of this is taking place, of course, in this context of healthcare reform, and where the goal is to increase access and quality while cutting costs. And if they would have only done the first two, we would have really been very happy, die nu. To decide to cut costs while doing this is incredible. And it's a pretty major initiative on the part of our country, and I think that one in which we need to really provide data on what impact this is having, because a lot of these programs are really stretched to the max. They're already not doing what they need to do, and cutting costs will only really disadvantage and exacerbate, disadvantage kids and exacerbate the disparities that we're seeing. So I just want to end, access, cost, quality. Can we have all three? And I want to reflect Aaron's comment from earlier. Even in hard times, priorities exist. And, I think that if we can't get the country to prioritize children, I think we're in big trouble. So in conclusion, we found significant disparities in access to outpatient specialty care for children. This was not inpatient, remember that, okay? And for children who had public compared to private insurance. And these disparities were directly attributable to provider non-acceptance of public insurance. And this is a barrier that's potentially modifiable through policy interventions. And any other attempts to reduce barriers related to transportation and language and all this will fail if we don't address this first. I'm not saying we shouldn't do those other ones, but this has got to be sort of fundamental. And I just want to acknowledge quite a few people, including the state of Illinois, health and disability advocates, a lot of the people I've worked with, and my wonderful doctoral student, Joanna Biscayer, who now works for the Attorney General, and they're monitoring healthcare reform, right? So, and lots of expert panel members who participated. Hal Yee was on my expert advisory committee, and he's here. And I think a lot of the stuff that he proposed, sort of increasing the efficiency by which we provide specialty care, making those scarce resources go further, I think have a lot, are going to be helpful in terms of solutions. So I'm going to stop there.
Karin, thanks so much. I've had the good fortune to be with you all day,
Yeah.
so I feel this has been a real treat for those of us at UCSF, and I'd like to take questions from the audience.
Thank you. That was really great and very informative. And I think I might have not seen one of the slides correctly, so before I ask my question, it looked like on the slide that showed academic medical centers were significant and neighborhood was significant, it also looked like presence of a pediatric certified provider at the clinic was significant. Is that correct? Or it had an odds ratio?
Actually, nothing else was significant on that.
It had a p-value of 0.02 and an odds ratio that didn't span 1.
Yeah, you're right. The p-value, you're right, is basic. That's true, and I should have.
So now for my question.
Yeah.
Sorry, I just wanted to clarify. We were having a discussion earlier about the fact that there are a lot of adult non-certified providers around who probably skew the results in a negative way because they're not taking Medicaid patients. So a regulatory approach might be to try and make sure all patients with a given diagnosis are directed to pediatric board-certified specialists, because then you'd get the insured patients going there by regulation, and you'd get less discrimination based on this
Right.
data.
Yeah, and I think I didn't highlight that because we already knew it from the literature, that pediatric specialists are more likely to take Medicaid patients. They almost all do. And for
It's
the
just your
yeah.
data is so powerful
Right.
that seeing it up
Yeah,
there.
I should definitely highlight that in my next. But one thing is are there enough pediatric specialists to do that? But Hal Yee's idea of actually using experts to provide basically consultation to primary care providers, this would be the group you'd want to use. They're already seeing them, and why not pay them more, and you need fewer of the people who are not willing to see it, and have their expertise be extended a little bit further to provide basically CME to primary care providers so that they could manage things like diabetes and new onset seizures. Or if the kid needs to get in, they get in based on medical need, not insurance status. So this is actually pretty well defined in the literature. The pediatric specialists are heroes. Yeah, so yes, go ahead.
I'm glad to be a hero.
Yes.
So I'm a pediatric pulmonologist, and one of my question is that I've worked in 3 different academic medical centers. My impression is that there are some private general pediatric practices where for asthma, a very common problem, that they will inappropriately refer to the specialist. I mean, they're asking us to do care that they should be able to do in their own practice, but because these are Medi-Cal patients, they pass them on and they shift the costs to our practice. So has anyone looked at that? Did you look at it? Could you look at it? And is that a correct impression or not?
So qualitatively, I think that issue was raised, but I didn't look at it quantitatively in terms of realize these aren't real kids. We're using simulated patients, but you could test that, and it's a good empirical question.
They actually did a study where I did my fellowship about ear tubes, sending kids who had like one ear infection for ear tubes when they were Medicaid, versus waiting for sort of the AAP guidelines of when you should send kids for ear tubes when they were privately insured, and we looked at that. And we actually did not find a difference where kids with Medicaid were referred too early to sort of try to take care of this issue with tubes. But it's just one very small part, maybe different from asthma.
I would actually... I wonder, it seems like most of the literature says that kids who are insured by Medicaid are more likely to have delayed care and not be referred to a specialist. In Illinois, a lot of the primary care docs said that they didn't even bother to refer when they thought the kid couldn't get in because they had Medicaid. So I'm not, I think it's testable, but I'd be surprised if that would be positive. So on a empiric basis.
And I just wanted to say, in terms of the subspecialty surgical, trying to get it to just be peds subspecialty trained folks, the revolt that would happen amongst the academies of all these surgical specialties would be it wouldn't be possible to get only peds surgeons to do peds cases, because probably a third of a general otolaryngologist's practice is peds. And they are not, it's actually very threatening to them, that the growth of peds otolaryngology fellowships, because it's threatening their practice. It would be very, very difficult to wrest that away from them.
Karin, that was a great talk. 20 days, even if you have commercial insurance, wait. And, an issue that strikes me is that, I was thinking about the scenario with the diabetes. And it's just hard to imagine that, someone with those signs would not be seen earlier. So the question I have is, did the physicians in the practice, were there any practices where they actually looked at the calls, the referrals, and made suggestions that they be seen sooner rather than later, because, there were some significant problems, and you did that purposely, obviously,
Right.
but most physicians, specialists would look at that and say, well, we can't wait 3 weeks to see that child.
No, there was very little medical triage. It was almost all receptionists. I remember, and I would go listen in on the calls. This is at a call center, and a kid who had gotten an appointment within, 3 weeks with private. This is an endocrinology case. The kid with Medicaid was given an appointment in a year. I'm like, what? And they said, we know that's not reasonable. Why don't you go to Cook County? So they have a public hospital, and there is a fair amount of, that's where dumping was originally described.
I have a question. So I'm a pediatric orthopedic surgeon, and orthopedic surgeons are the bad ones up here. We've actually been publishing in our literature for a long time on these disparities. So the Scaggs published back in 2000 a study that showed basically the same thing in terms of access to orthopedic care for children in California. So this transcends obviously Illinois, which we all know. But at that point, in doing these calls between privately insured and publicly insured children to 50 different orthopedic offices in LA County, all 50 got appointments if they had private insurance, and only one of the 50 Medi-Cal kids got an appointment. We actually just repeated that study this past year and did a 10-year follow-up, and now what we're showing is that children in general don't have access to care, because even the privately insured kids are not getting into the specialists. But that study, that was now 13 years ago was when that first study was done, and it put out on the table, at least in orthopedics, put out on the table that there's this huge disparity. The CPT code for the issue that we're looking at is, reimbursed at $80+ for the privately insured child and $14 for the Medi-Cal child. So, and all that's happened is it's gotten worse. Yeah. So where, your data is obviously phenomenally powerful. It's published in the New England Journal of Medicine. Our studies are small. They're published in either orthopedic or pediatric journals. But that same study's been reproduced in Florida. And how do we get people to pay attention to this? And how do we move forward? Because we're all dealing with the same thing of how do we get these kids cared for? And unfortunately, so much of it comes down to money. And so what do we do? What's next?
So I'm curious. I'm thrilled to talk to someone who did that second Scaggs study. Why do you think they stopped seeing kids? Because they weren't seeing privately insured kids either.
We specifically were looking at adult, so going back to what we were talking about, where pediatric surgical subspecialists can't take care of all the routine problems. Yeah. And so this was actually, the scenario was a kid without a growth plate fracture that didn't need anything but a cast, basically. And so there really is not a need for a pediatric subspecialist in that situation. So we were surprised also to see that change. What we had hoped to see is that there was some sort of increased access for the Medicaid children, but in general there was decreased access for all. And I think it has to do with increased subspecialization within our field. I think it has to do with increasing medical legal environment where people are afraid to take care of kids, because if something goes wrong, the statute of limitations is 18 years in some states, 25 years in others. It's not just 1 or 2 like it is for when they're taking care of adult patients. So we sort of think it's multifactorial along those lines, and we don't have an easy solution for that either, unfortunately. Yeah. But the disparity persisted. Half of the privately insured kids got appointments, and only one of the Medicaid kids did. So,
I actually think producing data, and I thought that was a pretty powerful study to be repeated 10 years later. I thought that was fabulous. The only thing is it left out the pediatric academic centers that provide so much care, but you wanted to repeat the same one. I think the fact that access is getting worse for privately insured patients is something that helps move policy, because it's sort of like, now it's it's my insurance and my kids you're talking about, and people who have more influence. Let's say the poor do not have good, lobbyists. They have really lousy lobbyists, and you are their lobbyists. Actually, pediatricians are some of the best lobbyists for children there are, and for poor children. And I think that you got to just keep getting out there and doing the type of stuff that the Children's Specialty Care Group is doing, and keep going to the state. And this group did block that 10% cut in kids. And I think that's because of organization. I think you have to keep doing it. You got to keep telling them, sort of like, keep telling them till they believe it, and make them believe it, and let them know that we can't ignore it. So I think that study that shows that access is worse for privately insured is actually very powerful and ought to get out there and be looked at as well. And you can't, without comparing it, if you just looked at Medicaid and didn't look at that, you wouldn't know. And I found that it's all worse for adults, by the way. It's all worse for adults. And, I take care of adults too, and young adults, I think that we have to advocate across the board. I mean, children are a more sympathetic group, but I do think we have to advocate to move and change the system.
So what is the continuation of the story in Illinois? So that they, I suppose, were pretty surprised by these disparities persisting. How are they responding to these?
They're trying to go to care coordination. They're mainly fee-for-service. But they actually, after the lawsuit, they switched to primary care medical home network, and they have some disease management as part of that. And there was just a big review that was done that it actually saved the state a whole lot of money. But the state is actually broke, and they're well-intentioned. I've been working with the, state Medicaid people, and they're trying to figure out how to do more for less. And so it isn't an easy environment, and they are very much into sort of pushing the political process.
If anyone has any additional questions, maybe they can come up and just ask her offline here. But thanks so much for coming. We've had a great day, and we really appreciate that.